All right, so I wanted to welcome everybody back to the Hand Fellowship virtual debate. This has been, for those of that have joined us in the past, this has been my opening slide. A little bit of a boxing match between the fellows. So for 2020, 2021, we're going to be easing into it. So instead of a traditional virtual debate format, we have a webinar with some gurus and some sages from across the country, and we actually have Dr. Lalonde from Canada joining us today. So this has been, for the most part, it's been a face-off or sometimes a cage match between fellows from different institutions, sometimes 2, 3, or 4 different fellows going at it. For week 1, I think we had a great wrist arthroscopy webinar with the professors, with Dr. Osterman, Gofarb, and Kakar, giving us a kind of a whirlwind tour through wrist arthroscopy, some of the key pearls and tips for success, and also what they should try and learn during fellowship. And starting next month, we're going to be going back to the traditional format, doing a virtual debate between fellows that will be facing off. So the schedule is going to be the 3rd Thursday of every single month, starting October. And we're trying to really recruit fellows and faculty from across the country. So certainly for any of the fellows or faculty who are on the webinar today, if you're interested, please reach out to myself and Dr. Hammer if you want to be involved in the process. So looking forward to a few little matches coming up. So save the date. So we're looking at distal radius fractures for October 15th. November 19th is going to be looking at thumb tip reconstruction, looking at toe transfer versus local coverage versus osteoplasty. And then Dupuytren's contracture release for December 17th. So we're looking at a kind of a once a month format for this. So again, it'll be following the format of having the fellows present in a lively debate and followed by a moderator with faculty panel for Q&A afterwards. So I'm really excited. We have a phenomenal panel of faculty educators who are going to share their wisdom on Flexor tendon repairs. We have Dr. Leversedge, Dr. Lalonde, Dr. Seiler, and Dr. Osei. I'm going to leave the more formal introduction to Dr. Leversedge in a few minutes here, but really want to thank all 4 of you for joining us on the faculty today, for joining us out of your busy schedule. So again, really thank you for your time. And again, I'm going to leave the formal introduction to Dr. Leversedge, but the theme today is freely sliding flexor tendon, capable of restoring good function. So the 4 lectures are as listed here. And I'm going to hand it over to Dr. Hammer right now. So all the debates from the last 6 months have been recorded and are posted to HandE. So if you do a search on there, and also want to give Dr. Hammer the platform to share what HandE is all about. So he's really done a phenomenal job with HandE and all the resources out there. So I'm going to hand it off to you now, Warren.
Okay, go ahead and hit the next slide, please. So thanks, Jerry. So I'm the editor of HandE, and hopefully everybody's aware of it and knows what it is, but I thought I'd just run through a few things for anybody that doesn't. This is free for residents, fellows, anybody that wants to sign up. So if you go to the ASSH site and log in, you can create an account, and then you'll have access to the content of HandE. Go ahead. So as the disclosure, I am the header. So I think there's sections that are very helpful for fellows and residents, and these are 3 that are probably the most beneficial. The Hand 50 series, which is a lecture series that was put together, started by President Boyer, and basically there are lectures on the 50 or so key topics in hand surgery. And so there's several topics that have 2 or 3 different people presenting, but they're lectures from fellowship directors and key educators in the Hand Society. And I think there's some really valuable pearls in those lectures. The Fellow Shoe is a weekly email that gets sent out with a couple of videos on various topics. They're kind of linked together, and things from that are not as common, like infections, high pressure injection injuries, to more common things like distal radius fractures. And then this fellowship debate series that Jerry has mentioned, that was started back in late March, early April. And there are controversial topics, really. So for example, proximal pole scaphoid non-unions. How do you manage that? There was a debate from 3 different fellowships about different techniques: vascularized bone graft, non-vascularized bone graft, salvage with medial femoral trochlea, salvage with costochondral rib grafts. So a variety of topics like that. Go ahead, Jerry. There's also a resident and fellow reading list. There's some review modules with questions. And then from a standpoint of surgical videos, if you're looking for techniques, there are recordings of surgical videos, predominantly in the video theater. So these have information such as indications, contraindications, and outcomes for any particular procedure. And then the comprehensive review is essentially the board review course that hand surgeons will take before they take the subspecialty exam. And so those lectures are there that are used to prepare for that. Okay. This is just an example of the fellow shoe topics that we have. So when you go to the resident and fellow section, all these things are listed. You can click on any of the previous ones. We're up to about 17, I think now, and they're all archived. So you're able to go back and look at any of the things that have been selected for that. This is just an example of the Hand 50 series. These are some of the more commonly viewed videos, one by Marty Posner on finger extensor mechanism. Bill Kleiman has a phenomenal video on examination of the wrist. So that's everything that you want to know about examining the wrist. It's pretty long, but it's many pearls there. And I think even practicing hand surgeons will pick up something from watching that. Go ahead. And these are just some of the recent fellowship debate videos, radial nerve palsy, where we debated nerve transfers and tendon transfers, scapholinate ligament injury, stage 3 Kienbock's, thumb arthritis. There have been a variety of topics that I think have been really good and helpful. And then this is the fellow shoe. It comes with a couple of videos, and then there's some questions and answers that you can go through to create kind of a learning module for yourself. So next. Just an example of the reading list. Any of the articles that are published in the Journal of Hand Surgery are available there for direct links. Anything that's not published in the Journal of Hand Surgery, we can't legally post the article because ASSH does not own it, but fellows should have access through their institutional libraries. These are the review modules. So if you want to go into a learning module about any specific topic, you can click on a link, for example, burns or carpal instability. You can go to the next one, Jerry. You'll have a pre-exam, so you go through, and there's anywhere from 6 to about 15 questions on most of the modules. And then after you complete the questions, you'll go through some learning material, which are a combination of videos and reading material. And then you'll take the post-exam, which are essentially the same questions you had before, and show that you have mastered that material. Next one. So this is just what it looks like. You'll go, this has 5 PDFs and 3 videos that you'd go through, and then you do the post-test questions when you're finished. And then just to sum things up, the video theater have video techniques, but more. They have information about indications, contraindications for the procedure, outcomes, references to peer review literature, and then the comprehensive review, which is nuts and bolts. No, that's fine. So the nuts and bolts of hand surgery, key learning material. And then finally, there is an app. So you can go to the next one, Jerry, that you can play on a pad or a tablet or a phone. And one of the cool things about it is it will remember where you are. So if you're watching a video on the app and you come back later, it'll remember your starting point. If you're watching on the app and you go to your desktop computer, it'll remember what you've recently viewed and where you were. So if you're in the middle of a video, you can pick that up right where you were. So I think that's one of the really beneficial things about the app that we have. And so that's really the nuts and bolts of Handy, the things that I think are helpful for residents and fellows. And so hopefully you'll take advantage of all the learning opportunities that we have. So thanks, Jerry.
Yeah, thank you, Warren. Yeah, thank you for all your work on this, Warren. It's been a great resource for the fellows and residents in our program for sure. So I'm going to hand it over to Dr. Leversedge from University of Colorado, who's going to kick us off with our Flexor Tendon webinar.
Great. Jerry, can you see my screen okay?
Yep.
Great. Well, thanks, Jerry and Warren, again, for this is a tremendous series, and we've all learned and benefited from your work. And so it's a fun part of both debating, but also in this part of the series, it's a great way of reaching out and working together with colleagues. And so our topic is flexor tendon injury and repair. And I have the privilege of working with Dr. John Seiler, who's at Georgia Hand and Shoulder and Elbow, Don Lalonde, who I think everyone knows is up in Canada. He, as a Canadian, I was allowed to bring one Canadian into this debate. Dr. Dan Osei, who's at the Hospital for Special Surgery. And the format of this presentation is really to try to review in a short period of time some of the pearls and pitfalls and the basic concepts of flexor tendon repair and rehabilitation. And you'll see our agenda here, and we'll start out with a small case presentation to give you a sense as to what's important about flexor tendon injuries. Dr. Seiler is going to talk about zone 2 repair methods, concepts that influence outcomes. Dr. Lalonde is going to talk to us about wide-awake repair methods that actually let him sleep at night. And then Dr. Osei is going to talk about distal repairs that don't keep him wide awake at night. So hopefully at the end, we'll have 15 minutes or so to go through a few cases just to have the faculty discuss some of the concepts in more of a clinical format. As you may have noticed from the topic title, this is actually, I think, an important observation that Guy Pulvertaft had many years ago, some 80 years ago almost. And he said, it's not difficult to suture tendons and prepare the ground for sound union, i.e. putting in the sutures, but the real problem is to obtain a freely sliding tendon capable of restoring good function. And I think for the fellows who are here and the residents, if you have done a flexor tendon repair, the downside is you probably haven't been a part of the follow-up care afterwards to see the struggles that we see following a flexor tendon repair, particularly in no man's land. And so these types of injuries are real clinical challenges, not only because of associated injuries, but just getting the normal gliding, the normal sliding tendon back together again, and to keep it sliding without peritendinous adhesion formation and without failure. So really the key points that our faculty is going to point out to highlight the anatomy, the biology of tendon healing is unique to this area of injury, the surgical techniques that will hopefully give us success, and importantly, again, just as importantly, if not more importantly, the postoperative rehabilitation. So I want you to think about this case as the faculty are talking, and if you can think about going to see a patient in therapy, and this is a patient 3 weeks after a zone 2 flexor tendon repair, who in therapy all of a sudden notes this unusual phenomenon that the finger, as he tries to flex to make a composite digital fist, the finger actually extends, and he's worried that you've hooked things up in an incorrect manner. And I hope everyone has maybe seen this or at least understood it to the point of understanding the anatomy of why this occurs, because it does present a little bit of a clinical challenge. So here's the anatomy. Remember that your flexor tendon injury, somewhere along the line, you've got a disruption, and there's a disruption in terms of the force through your proximal muscle to the distal fingertip, the target. And if that is not allowed to transmit this force to the fingertip, remember your lumbrical origin at the FDP, and as your patient is trying to actively flex, because there is no force going through the tendon, it's now bypassing the tendon and passing through your lumbrical. And as you all know, the lumbrical inserts through your extensor hood, through the oblique fibers of your extensor hood, through the conjoined lateral bands. And so the effect of the proximal traction against the FDP tendon is now you're extending the interphalangeal joints of your finger. And so that's your paradoxical digital extension. So why does this occur? Well, there's no gliding tendon. So it's either that your repair has ruptured, your repair site is too bulky to pass through the fibroosseous digital tunnel that the tendon needs to pass through, whether it's at a pulley, whether it's too large of a repair, or where you've got some peritendinous adhesions, the tendon is no longer gliding. So those are the three things that we think about, potentially amongst others. But when you have a patient early on in your repair, you have to try to figure out, why is the tendon not gliding as it should? So Dr. Seiler will lead things off with zone 2. Remember, this is a unique environment, an intrasynovial tendon. Dr. Lalonde is going to talk to us about trying to avoid this catastrophic failure of a repair, particularly with some intraoperative techniques that allow us to visualize the tendon as we've repaired it. And then Dr. Osei is going to talk to us about what may not look at first glance importance of getting from here to here, but we all know that when our patients can't actively flex the digit to create a composite digital fist, that it really does reduce functional activities. So without further ado, I will pass this along to Dr. Seiler, And John, if you're able to take over the screen here, I will send it back.
Fraser, how's that? Can you see it okay?
Perfect.
Let me see if I can expand it maybe just a bit. Well, I'd like to spend just a couple of minutes talking about Flexor tendon repair in zone 2. You know, I'm having a hard time.
Are you able to do slideshow on there, John?
I've tried to get it. Mine doesn't seem to.
Can you click on your slideshow where it says view 2 spots over on the top there? Keep going right. Right. Up on the top it says slideshow right next to animations. There you go.
I usually use the bottom one. It doesn't seem to want to flip over there, Fraser.
Or go over to the left and click normal. Is that right next to outline view?
Not really sure it has worked. Well, Fraser, do you want to go ahead and grab the next presentation? Let me see if I can fuss with this for a minute. How about that?
John, do you want to stop screen share and then see if you can get it started and then start screen share again?
Yeah, let me see if I can try one more time.
Don, why don't you take over?
Okay, can you hear me? You see my screen?
Perfect.
All right, we're on. John, I think if you hit home there, you're going to get it.
Okay, I'll try.
Yeah.
I don't know what was happening there.
Yeah,
Thanks.
you'll figure it out. So there is a book, but I'm not making any money on it. That's my disclosure. There is a website, which is also very helpful. I'm not making any money on that either, but they're good sources of information. So I have to tell you that my results in Flexor tendon repair used to suck terribly when I was a young surgeon, and they still occasionally suck, but most of the time in most good patients, I'm now getting good results. And I'm not having to do a lot of tenolysis anymore, and I'm not having a lot of rupture anymore. And I think the two biggest reasons are doing them awake, and also true active movement post-op instead of full fist place and hold. And I'm going to go through some of that stuff. I'm going to talk to you about what I think are the most important things, and it's not just wide awake surgery. I think these bulky repairs like Fraser talked about are really, really good repairs. And if you haven't read this paper by Jinbo Tang from 2017, you should. I think it's almost as important as Harold Kleinert's 1967 paper on early movement. 300 tendons, young surgeons, almost all of them got good results and only one rupture. And they all had these bulky repairs. And I'm doing this 6-strand repair now, but I think for way too many years, we focused on the suture. It's not about the suture. It's about a good damn solid repair. That's what it is. You need a good solid repair. And the problem with a bulky repair is that we used to think it had to fit through those damned A2 and A4 pulleys. And I used that word appropriately. Damn the A2 and A4 pulleys. They cost us 50 years of unnecessary rupture and tenolysis because we prayed to the altar of you can't sacrifice those things. And this is on the right, that's a grandma kiss repair. I actually published that drawing and I'm embarrassed about it because it's a poor repair. But I used to think it was a good repair because I needed to get underneath those damn A2 and A4 pulleys. And it's called a grandma kiss repair because the ends of the tendon are just touching, just like when you kiss your grandmother on the cheek, you know, like, right? And Here's a grandma kiss repair. I mean, they look beautiful. This patient's awake on her belly. It's an easier way to do the thumb. But watch what happens when she starts to stress it with active movement. It starts to gap. And you're thinking, oh, that's going to be great. Bullshit. It's not good at all. And we all know that the gap turns to rupture. And we know that happens about 7% of the time. But if they're awake, you can fix it. So if they get a gap with active movement because your tendon repair is not tight enough, and one of the biggest reasons that I used to get ruptures and that a lot of us get ruptures is our freaking repair is not tight enough. So make it bulky, like make it like it counts. And then you're going to be able to vent the pulleys so your bulky repair fits. That's the whole deal. And we know it happens 7% of the time because of this series of over 100 patients that I published with Mike Bell from Ottawa, where 7% of the time these grandma kiss repairs came apart when we watched them with wide awake repairs. And we were able to fix the problem, but if you're still doing them asleep or with a motor block, you don't know that's going on. And so, you know, a few weeks later, your repair comes apart. And so what you want to do is a bulky repair that's not going to gap and that's going to fit through vented pulleys. That's the new deal, is venting these blasted pulleys. So this patient has A4 vented, A3 intact, and there's no clinically significant bowstringing on the table, and there's no clinically significant bowstringing after surgery. And I use the word clinically significant because a little bit of bowstringing never killed anybody, but a stiff finger is useless. So I'll take a little bit of bowstringing any day. This one has venting A3 and A4 with no clinically significant bowstringing during or after the surgery. And I could show you dozens of these. And this one is one that whoops, sorry, we're gonna go back there. This one is one that I did
2.5 centimeters of tendon sheath. Bring them in all the way. Fantastic. And straighten out all the way. Okay, you're not getting stuck. We're in good shape. And flex again. And straighten. And we're 3 weeks after tendon repair. Let's just have a look. Yeah. Beautiful. Because now I'm seeing that DIP joint move. Good. Okay. Yeah, beautiful. And straighten out. We're now 5 weeks after tendon repair. Oh, that's lovely. Look at that PIP extension. I like that. And do it again. Flex again. Wrist extended a little more. There we go. Great. Fantastic. And then put your hand on the table here, like that. There we go. And flex. And extend. And flex. And extend. Great, let's take the Coban off.
So you don't just whack out the pulleys. You incrementally divide just as much as what you need so that your fat repair fits through without getting stuck. So here, I got my first core suture in. This was before I was doing Jinbo Tang's 6-strand. And I see that I need to divide a little more cruciate pulley. I can leave my A3 intact in this case because it's not getting in the way. And so you just take out as much pulley as what you need. You don't just go whacking everything out, but you got to take out whatever you have to so that at the end of the case, they're getting a full range and they're not gapping. And so she had A4 vented, no clinically significant bowstringing during or after the case. And the new rule, forget the old A2, A4 business. The new rule is up to 1.5 to 2 centimeters of pulley venting. Because if you do that, You're never going to vent both A2 and A4. And the case that I just showed you where I had to vent A1 and A2, I still had A3 and A4. And yeah, there's probably a little bit of bowstringing, but at 5 weeks, he almost had a full range. I'm going to see him tomorrow, and he's got, my therapist tells me he's got a full range now. But this rule is in Jinbo Tang's 2017 paper, the one I said that all fellows ought to read, because you really should. I think it's critical. But I think probably the most important thing about wide awake repairs is that after you're done and you do full fist flexion and extension testing, you know that there's no gap. And if there's no gap with a full fist today, then there's not going to be a gap with a half a fist 4 or 5 days from now. And you always elevate and immobilize 3 to 5 days. Let the swelling come down, let the work of flexion come down, let the bleeding stop, and let them get off painkillers so they can do pain-guided healing. And you always know this way that you vented just enough pulley that you're not going to have to do tenolysis. You know, it's like testing blood flow after a vascular anastomosis. You don't just do your repair and hope it works. You let your clamps down to make sure it doesn't work. And when you simulate full fist place and hold, so there's true active movement, okay? And that's what we're recommending, up to half a fist of true active movement. Here's what happens when you simulate full fist place and hold. See halfway? It stops moving. It's buckling. It is not passively moving. And when you say hold it, watch it jerk right there. I'm going to show you that again. It stops moving about halfway, and then you say to the patient, hold it, and there you go with full fist place and hold. Jerk right there. So we call that buckle and jerk. And so this is what we do now, up to half a fist of true active movement. So there's 3 fingers with cut tendons. There we are at 4 days doing up to half a fist. But really you want to get the DIP flexing. It's not about MP flexing. It's about the hook fist. Push the hook. Jinbo Tang takes them right out of splint for exercises. And we're doing that more and more. So here's what I think is one of the most important things, and that's talking to the patient. And I told you I still get the occasional result that sucks. And this is one that I remember very badly because I spent my whole case educating the resident on how to repair this tendon. And I totally didn't talk to the most important person in the room, who was the patient. And I missed the fact that he was a drug addict and he went and shoveled snow the day after surgery for drug money. Now, he probably would have done that anyway. But at least if I'd have talked to him, I might have picked it up. Instead, I ignored him. And
so let me explain the theory of the movement that we're going to do when Amanda starts you moving on Friday. The goal is to move it just a little bit so it doesn't get stuck, but not to move it too much so that it rips apart. It doesn't take much to rip this apart because the stitches are only about 1/10 as strong as your tendon. You're not going to use it at all. You're just going to move it just enough to keep it moving so it doesn't get stuck. What's the most important rule when we get you to start moving it?
I can move it, but I can't use it.
Important rule when you start moving it on Friday?
I can move it, but I can't use it.
So it's Monday morning. You've got no Advil, no Tylenol on board. We're 3 days after the flexor tendon repair. And what's the most important rule when we let you move it today?
I can move it, but I can't use it.
you know, a flexor tendon repair really changes somebody's life. And so my favorite question is, so what were you planning to do this week? Because almost inevitably that person has to change the plan of their life. And there's nothing like during the surgery when you have their uninterrupted attention and their unsedated brain listening to you to go through a possible new plan that's actually going to work so they don't screw up your result. And more importantly, they don't screw up their hand. And relative motion splinting has been really, really valuable to improve extensor lag. This is a fifth finger repair. And after 2 weeks, he gained 20 degrees of active extension because they exercise while they're living. And instead of hyperextending their fifth finger, they're extending their PIP joint. And this, a relative motion extension splint, when your patients are stuck in scar, because that happens a lot. They come in, you do your ultrasound. By the way, a real hand surgeon today has an ultrasound probe in his clinic around his neck, just like a cardiologist used to have a stethoscope around his neck. So if you've got an ultrasound probe in your clinic, you check the tendon, make sure that it's not ruptured. It's just stuck in scar. That's great. You put them in a relative motion extension splint, which helps differentiate the glide between the profundus and the superficialis, and they exercise while they're living. And you're going to avoid a lot of tenolysis if you use these splints and your ultrasound. So in summary, I think the 7 most important things to consistently get good results with clean-cut repairs in reasonable patients is at least a 4-strand, very solid repair with 1 centimeter bites, bulky, judiciously venting up to 1.5 to 2 centimeters of total pulley, intraoperative active full fist flexion and extension testing to make sure that your repair fits through the pulleys and you've vented them well enough, and make sure that they're not gapping. Teaching your patient during the surgery instead of talking to the nurses about the weather or the anesthetist about his new sailboat. And up to half a fist of true active movement post-op, and relative motion splinting to improve flexor and extensor lag. Thanks very much. I'm going to stop sharing. There we go.
Thanks, Don. That was great. I think we all appreciate your work with Wallet, and that being down in Honduras and seeing it in action is very impressive. John, are you good? You're on mute though.
John, you're still muted. You got to hit your mute button.
I was just excited that I might get a presentation up. Let me see if it'll go full screen so I can advance it. There we go. All right, I'm going to just make a couple of comments about practical aspects around Zone 2 repairs.
John, you need to click on share your screen.
Share your screen.
I did. Well, I'm struggling then.
On the bottom, roll your mouse over the Zoom and it's click on the green share screen.
Yeah, I got it. It doesn't look like, I guess I'm having some sort of technical difficulty because it says it's trying to do it, but it is.
Does it give you a choice of screens to share, John, when you hit share screen?
It says, let me try, hang on. See if that's any better.
There you go. You got it. You got it, buddy.
I'm not sure what's happening here, but we're going to try. Is that
it.
better?
Yeah, yeah. You got it.
See if it'll even work. So I wanted to just go through a couple of aspects around flexor tendon repair in Zone 2. And I wanted to start a little bit with some of Don's concepts around what kind of a patient are we working with, because I think the kind of patient you have really depends on the kind of suture you may want to place and certainly the aftercare. And then in our institution, we always have a big checklist of things that we need to run through in terms of our ability to do the case. We're trying to be pretty meticulous about that. I generally prefer mid-lateral incisions to Brunner incisions when it's possible, but I like to incorporate the existing laceration into the approach for surgical exposure. And then I do like to preserve as much of the A2 and A4 pulleys as possible, but agree with Don that really over the last 10 years, one of the big changes in how you approach the pulley system is you need to make sure that you have good tendon excursion in the OR, because it's clear that you'll never get it if you don't have it at the time you start the case. So here's just a quick example of an exposure. You can see a modified Brunner kind of approach. The annular pulleys have been preserved. There's a flap of flexor sheath that's been raised, which you can repair to the ever-present rim. There's one slip of the FDS and the digital nerves are intact. And I won't spend much time on McGrowther's technique of tendon retrieval, because I think that's going to be the focus of additional discussion. But sometimes I'll use this technique. Sometimes I like to use, I'll just retrieve the tendons proximally, place my core suture, pass it distally, and then just be ready to sew. One of the biggest problems I have seen over the years is with people not correctly orienting the tendons back in the middle of zone 2. And there it's just, it's good to spend just a minute thinking back on the anatomy in that area where the flexor digitorum superficialis is rolling around the profundus. And as it comes underneath it and cradles it, 50% of those fibers cross, and then the insertion runs out. And I think that's something that's really important in the OR, to get that as precise as you can get it, because that is a common source of complication when I see patients in referral. This simple anatomical principle hasn't been observed. One of the things when we teach flexor tendon repair, after we establish the tendons into the wound, I like to do the FDS first, do the FTP back wall, and then stabilization of the tendon becomes much easier. You can put a Keith needle or a 25 gauge needle through it. I prefer a 25 gauge needle, but that technique of doing the FDS first and the back wall first really simplifies the procedure so that you can teach the core suture method that you want to teach. And there's just the distal stump. So once you have everything in the wound, again, from a strategic standpoint, I always get the FDS stabilized first, because that helps me plan and perform the repair of the FDP. And I think if you do a back wall first epitendinous stitch on your FDP, that sets things up for success with your core suture. It just makes everything easier to do, and you feel like you're running downhill. When you think about core suture methods, remember that stronger techniques may be associated with more bulk. You may have to pay more attention to your tendon sheaths to make sure that they glide appropriately. And generally speaking, they're more technically difficult to place. And reproducibility is important in my view here. I think there's a lot of different materials that are appropriate for flexor tendon repair. I still am a fan of the looped caprolactam suture, because I can put in a 4-strand repair more quickly and easily with less handling of the tendon. I think that's a nice strategy for doing it, but certainly there's plenty of articles that show other suture types as being effective here. When I think of suture methods, I like to simply divide them up into 2 types. 2-strand suture methods, or a Kessler, a modified Kessler, Kajima's method, Suge's method. These are generally not going to be strong enough for early active motion, but are appropriate for early passive mobilization programs. And there's still plenty of cases that we see where that's an appropriate strategy for rehabilitation. The repairs that I think everybody prefers are the multi-strand, multi-grasp repairs. And one of the really interesting things about these repairs is when they're studied in vivo, in animal models, you don't see a lot of repair site strength softening here. So to Don's point earlier, you're gonna have good motion in the OR. That repair site is probably not gonna soften in the first 14 to 21 days. It's gonna continue to build strength. And over that period of time, an active rehabilitation method is probably gonna work out nicely for you. So the factors that influence the strength are the gauge of the suture, the number of strands, the suture geometry, the material, and then the biologic response to the injury and the repair, I think, is important. So some patients with very complicated injuries, I may choose a simpler tendon repair strategy, knowing I'm going to alter my aftercare, and I still think that's a fair thing to do. If you get a lot of industrial injuries and there are multiple fingers, you might change the repair site strategy, because you know that your aftercare strategy is going to have to be different. So for me, this is still an optimal type of core suture. I want sturdy coaptation of the ends. I like a low profile appearance of the suture. I want it to be strong enough to allow active digital mobilization, and I want it to be pretty easy to put in. So here's one way. Again, I'm going to show this with a single strand because it shows up better on the slides, but we use a loop suture because it makes it a little easier. So we're going to use a modified Kessler type strategy where the tendon, the knot will be internal to the repair site. And this is an easy way to get a 4-strand suture. You can add a mattress over the top, as Dr. Strickland used to recommend, to get to another couple of strands. And then we finish it with a deep epitendinous suture. Ed Diao showed that this definitely increases our not only the gap strength, it smooths the edges, but it adds a little bit of strength to the repair site as well. So I think it's a useful strategy. But the principal advantage of these sutures is they allow early active mobilization. You can look for increased tendon excursion. There are a lot of nice new rehab programs. Don's partial fist is a good example of that. And there's some biological evidence that you might even accelerate intrinsic tendon repair. But certainly these can be done safely. You're not going to have postoperative gap formation, and you're going to have a very low rate of tendon rupture. For the distal FDS repair, there's a lot of different strategies that are useful. A modified Becker is a nice strategy, but a lot of times this is a very short piece of tendon, and so you may be stuck with a mattress or a mattress in a figure 8 to get that together. And again, I choose the suture caliber there based on tendon size so that it can be done effectively. And here's just an example of a modified Becker type strategy. Sometimes you don't have enough tendon to work with, but this is a nice one. It's very durable if you like it. So here's a child's hand laceration where we've retrieved the FDP through a repaired now repaired FDS, and you can see it fits in there nicely. We've preserved the pulleys, and you can finish that repair off, and it's going to be a nice smooth repair. And you can see we vented a little more sheath there, just as Don had alluded to make sure there's good gliding there. What about sheath repair? The sheath repair is really something that there's no clear clinical evidence that it improves outcomes, so I think it's useful only when it improves the gliding of the repair site. The operative end game for me here is always the same thing. We got to check the tendon excursion, because if it won't go smoothly in the OR on day 1, it will never go. And then I vent or recess pulleys just to make sure that I can get full gliding, and then look at sheath repair only in the context of how it might facilitate repair site gliding. I like it to be nice and dry when I'm done because I don't want to fight through hematoma and other things that create increased work of flexion, as Don alluded to. And as Don also pointed out, the aftercare here is really important. And our goal is the same as Don pointed out. We want to safely allow differential tendon excursion so that they can get to a full fist. And we prefer, when possible, the early active aftercare methods. Dr. Gelberman and colleagues showed us that this is really important. He showed a nice cause and effect from more therapy causing improved digital motion in the end of care. And so there's good rationale for this for both passive and active programs. And I'll just show just a couple of quick cases. This is a guy that had a hand laceration that we fixed with a 2-strand repair. He took off his splint, never came back to clinic until he needed some paperwork figured out, and he had early active motion. And this is the case that sort of spurred my interest. But these multi-strand, multi-grasp repairs allow you to get to much improved motion for me relative to 2-strand repairs and passive mobilization tactics. You can see these work out. We have a very low rupture rate now with this strategy. And here's one that's a kiddo that came in about 3 months, 2-3 months out, and she had a complete FDS, FTP. You wonder if you could even repair it. And even in a child that's compliant, you can work an early active program and get a good outcome. And that's supported in the literature with a prospective randomized trial that shows improved outcomes for patients that had multi-strand, multi-graft suture method repairs and active or early active rehabilitation. And our poorer results there were really just smokers and crushing injuries. All right, Fraser, I think I'm going to stop there. Is that okay?
That is great. Thank you, John. So our last speaker is Dr. Osei. And Dan, if you can take the screen. Awesome.
You see my screen?
Yes, we can.
All right, let's try to go home. So we're running a little bit behind, so I've been trying to take a few things out of the talk as we've been speaking. These talks have been fantastic, and hopefully give the fellows and residents on the call a good sense of some of the newest and most important tactics, as well as important aspects to what is a very technical challenge for most hand surgeons, even now in 2020. I don't know that we've kind of solved this problem, although we're clearly getting better by the work of a lot of the folks that have talked today. So I've been tasked to talk a little bit about Zone 1 repairs, and there are certainly many similarities to what has been talked about with Zone 2 tendons, but I do think it's worth reviewing a little bit about some of the differences. So recall that Zone 2 is really the intrasynovial tendon, and once you start to get out of that area and have injuries where the tendon is inserting into the distal phalanx, some of the biology is quite different. And I would say that much of what we know about the vascular anatomy of the FTP insertion comes from the work of Dr. Leversedge, who's been moderating this session today, and he described the interosseous blood supply coming from the palmar surface of the distal phalanx, as well as from a leash of blood vessels exiting radially and ulnarly from the distal phalanx into the distal FTP tendon. And then more proximally, he also described that the FTP tendon gets direct blood supply from the vincula brevis profundus. And there is a little bit of this watershed area, which is a relative hypovascular zone, which can play a role in terms of the biology, and particularly may play a role in terms of the repairs, similar to what we see in some of the Zone 2 injuries with hypovascular zones. However, one of the things that Dr. Leversedge also described in one of his cadaveric studies is the neovascularization that occurs at the distal tendon stump of the FTP over time, certainly by 21 days, but even as early as 2 weeks. And that is sort of demonstrated by this clinical picture here, where you see the extra almost erythema, which corresponds to a picture from one of his papers. And so this is one of the reasons that in certain circumstances that we'll discuss further, it's possible to fix distal FTP avulsions at a later time from injury than we typically associate with Zone 2 injuries, where it's often paramount to get the patients into the OR within the first week. So when we think a little bit about this issue, one of the other reasons to address these injuries, that we're able rather to address some of these injuries later, relates to how they present clinically. And so I think most of the residents and fellows on the call are familiar with the Leddy classification, which describes the different types of FTP avulsions, with type 1 being the most severe, which is actually different than most of our classifications, usually getting more severe with increasing number. With type 1, again, corresponding to avulsions proximally, with both the FLP and FBP being avulsed, so their extrinsic blood supply being avulsed. 3 is the least severe, as the tendon gets trapped usually under the A4 pulley with no disruption of the vincular system. And then you have the type 4 and 5 injuries, which really correspond to bony distal phalanx avulsions. Number 1, in association with a retracted tendon, that's type 4, and then with a comminuted, usually intra-articular fracture of the distal phalanx, which is type 5. So as we see, essentially, depending on how much of the extrinsic blood supply is disrupted, that tends to correspond with how quickly we need to fix some of these repairs. So I think that's an important concept, particularly for the trainees, where type 1 injuries, as well as the 4 and 5 injuries, really need to be fixed quickly based on, number 1, the amount of blood supply disruption, as well as the bony injuries, whereas the type 2 and 3 injuries with preserved blood supply and being trapped closer to its insertion on the FDP. Typically, we have up to 3 weeks has been described. I still try to fix these a little bit sooner, but certainly it is possible to fix these later than we typically associate with flexor tendon injuries. I'm not going to perseverate on this. One of the things that we talked about discussing is how do you actually do your tendon repairs, and one of the things that hasn't been talked about that much is tendon retrieval. And there are lots of described techniques. Certainly as a fellow in St. Louis at WashU, Richard Gelberman was very fond of this technique of sommeliers, where you basically use an iced pediatric feeding tube and you feed it through the sheath with suture attached, and then you're able to drag the avulsed tendon through. And that works both for zone 2 as well as zone 1 injuries. There are a lot of other techniques. Certainly we'll try to keep this talk free of commercial influence. There are certainly commercially available tendon retrieval tools, as well as what was one of the more inventive techniques, using a reverse Esmark to essentially milk the tendon from proximal back distal. Now, fortunately, with a lot of the FDP avulsion injuries that we're talking about here with zone 1 injuries, the possibility of flexor tendons all the way in the forearm is less than with zone 2, but certainly knowing these techniques can be helpful regardless of the type of injury that you are facing in the operating room. So, talking a little bit about repair techniques, this is certainly an area that things start to go away from what we were talking about with zone 2 injuries. And there's a lot of information in our orthopedic literature. One of the biggest controversies relates to whether you use the historical pull-out technique, where typically a Keith needle or drill is taken through the FDP tendon after a repair has been done to the distal stump, and it's brought through the sterile matrix and then tied over a suture button. And this is in comparison to suture button techniques, of which there are many. And when you look at the literature, it's actually a bit mixed. This study from Gelberman and Matt Silva, looking at some of the mechanical properties, demonstrated that the pull-out suture technique was actually stronger with regard to ultimate tensile force required to disrupt the injury, but in terms of displacement of the repair, it was actually the weakest, meaning that when you have 20 newtons of force placed on the repair site, the displacement of the bone to tendon interval was greatest with the pull-out suture technique, as opposed to any of the suture anchor techniques. And so this was one of the studies that started to caution the use of pull-out suture techniques alone. When you look at other studies, one of the ones that I've certainly found useful is this one by Steve Lee when he was at NYU, and he looked at a variety of different techniques, and this was useful to me. He basically said that when you look at different configurations, a configuration using a pull-out technique with suture anchors is actually the strongest with regard to withholding displacement against cyclical loading, as well as ultimate load to failure. And so certainly the combination is something that you should consider. In terms of what matters, I think a lot of what was been talked about, certainly by Dr. Lalonde's talk, is the same. I think that although we've spent a lot of time and a lot of literature, a lot of words written down talking about suture size, suture caliber, technique, doing a good solid repair is ultimately the most important thing. I do like SuperMid, much like Dr. Seiler was talking about. I do like a looped suture giving us more strands across the repair site, but I don't think that it's as important as doing a good solid repair. So whether you use the pull-out technique, whether you use suture anchors or a combination, whether you use a Kessler or modified Kessler style suture or a modified Becker, which is commonly used at the FDP insertion, I think making sure that you've prepared the distal phalanx appropriately, that the tensioning is appropriate, and that your suture security is solid, those are the things that are going to make for the best repair and cut down on complications. One thing that is worth noting again for the residents and fellows is that the manner in which you place an anchor, if you are going to use one, matters greatly. So this paper looked at a couple of different configurations, whether the suture anchor is placed antegrade, meaning going from more proximal to distal in direction perpendicular to the distal phalanx, or going retrograde. And what they found is that both with regard to displacement to cyclical loading as well as ultimate load to failure, the retrograde, typically at a 45-degree angle, is the best and most optimal suture anchor placement configuration. So certainly if you're going to use the anchor, make sure that you do it in this manner. In terms of A4 management, I won't belabor this. I do think it's particularly important at the distal FTP insertion site, particularly as you're trying to go, about 1 centimeter back in terms of your repair. Many people, as we've talked about, are very comfortable venting the entire A4 pulley. It's been talked about at meetings. It's been talked about in this conference. I think at this point, as long as you're preserving the pulleys proximally to Dr. Lalonde's point, not venting more than 1.5 to 2 centimeters, it's perfectly acceptable to vent the entire A4 pulley with FTP, distal FTP repair. In terms of stump management, something that Dr. Leversedge thought that we should talk about, I think this is a common dilemma. Oftentimes you'll see that it isn't a clean avulsion of the entire FTP tendon from the distal phalanx, and so you have to decide what to do. Recall that if you have enough tendon and you resect it all the way down to the base of the distal phalanx, you may end up with quadriga, which is almost impossible to rehab your way out of, so you have to be careful. I called this level 6 evidence. This is just sort of my gestalt and how I manage this. If I have enough tendon, so 7 to 10 millimeters to do a good repair, and again, I typically use a Becker style repair, I do use tendon to tendon repair even with these zone 1 injuries. If less than 4 to 5 millimeters, more of a true avulsion, I would do direct tendon to bone repair. There are times that there's enough tendon that I think I can almost do a hybrid where I'll do my repair, I'll directly to bone, whether I use the pull-out or anchor, and then I'll repair some of the stump on top of the repair to augment and perhaps strengthen the repair. Make sure that you vent your A4 pulley if you do this, because it's certainly going to add to the bulk of the repair. And to the point made by both Dr. Seiler and Dr. Lalonde, you're going to have difficulty having FTP excursion across the DIP if you don't vent when you do this technique. In terms of complications, there are many, and this is one of the things that I think it's important to know and be aware of. There can be some horrible complications with FTP repair at the distal phalanx. This paper highlighted many. I mean, you can get horrible osteomyelitis, CRPS. I think that this report was probably a little too cautionary, with 15 complications reported after 23 repairs over about a 10-year period. But certainly technique matters, making sure that sterility is kept throughout the environment, despite the fact that the blood supply distally is quite good and usually will lead to a lack of infection. But certainly lots can happen. Be careful with your technique. So in terms of my approach, I still, despite some of the evidence against the pull-out suture, have really liked it. I will at times augment with a suture anchor. I usually don't use 2 suture anchors when I do the pull-out technique. And so I'll do similar to Steve Lee's hybrid, 1 anchor and then the pull-out suture through the sterile matrix over a button. I find that to be a reliable technique. I generally have not been as good as some in terms of doing wide awake surgery, although I have, with increased frequency over the last couple of years, used that technique for all the reasons highlighted in this conference. And certainly if you're not going to do it, I will say that I'll do some tenodesis to get a sense of the excursion. Again, the point I made about quadriga and making sure that you've tensioned your repair, particularly distally, is quite important. And so this is your chance to make sure that you get it right. I think that if you can't do a little bit of tenodesis on the operating room table without having gapping, to Dr. Lalonde's point, you probably have to do a stronger repair, and it's probably worth doing it again. So that's typically my approach for that. So with that, I know we're running over. I'll turn it back to Fraser, and if there is any time left, we can answer any questions.
Great, thanks, Dan. Thank you, everybody. I've gotten an appropriate, let me find my screen here. So we're gonna play one case here, just because we're running a little bit over, but I think it's probably helpful just to consider one of the issues that in terms of timing can be a little bit of a challenge for many of us in terms of decision making. And I'm gonna play this case here. So this is a patient comes in 2 months after zone 2 flexor tendon repairs. And for our faculty, I'm curious as to your sense of timing and your sense of strategy. So the patient's able to flex a digit, but only to roughly about a DPC of 2 centimeters, 3 centimeters. There's full passive flexion, and there's an intact active FTP function with distal P2 blocking. Passive extension is to approximately 20 degrees at the PIP joint. Dan, Don, and John, a quick 1 minute just to explain your strategy for obviously possible tenolysis, and what is your sense of timing for this type of a patient who's 2 months from surgery? John Seiler, do you want to take a go at this?
Sure. For me at 2 months, I would still be optimistic he would gain some additional improvement in therapy. So I would keep working with therapy. I would probably increase the frequency of his therapy, make sure he's on a good anti-inflammatory medicine, and follow him closely and try and keep him moving forward with his rehab. For me, the window for tenolysis usually starts between 4 and 6 months. And then at that point, if he had full passive limited active motion, which is the scenario that looks to be developing here, at that point, he may be up to around 90% of his total active motion. So I would go ahead and offer him a tenolysis at that point. But that would be my approach in this early phase.
Don Lalonde, any thoughts?
Yeah, I think that 2 months is too early for tenolysis. And I think I'm in with John that I don't like to do them before 6 months. And even then, I think that's often too early. And I think a relative motion flexion splint here might improve your your PIP extension. Sorry, I don't know what his MP hyperextension looks like, but certainly that can be a helpful strategy here. I think if I'm going to do a tenolysis, I want the skin and subcutaneous fat to be soft. When I palpate it and move it around, because that's a reflection of what the paratendinous adhesions are like. Like if you go in and the skin is hard as rock and stuck to everything inside is going to be concrete. So you got to wait for that to soften up before you're going to have a shot at that. And in my experience and view, if you don't have decent passive movement, you're not going to win with tenolysis. And so I think you're going to go from a stiff finger to a stiff finger if you do tenolysis in this person at 2 months.
Great, Dan?
All great thoughts, and I think I share a lot of similar sentiments about this. I generally don't do tenolysis earlier than 4 months. I've actually had a patient rupture following tenolysis at 6 months. So I think the longer I go, the more I wait. There's a few things here. It's funny, I was just talking to my fellow about this kind of situation with stiffness. So full passive flexion, so there's nothing going on the extensor side tethering you. So there's some issue with the flexor. And yes, with FDS, FDP, you're worried about the lack of differential glide. I'd also worry potentially, depending on how you did the repair, that perhaps there is some pulley insufficiency here that's playing a role. And so some of the time I may, although 2 months would be too early, consider getting ultrasound, again, to Don's point, making sure that I have a good understanding of the issue, whether it's true adhesions between FDS and FDP, or whether there's a mechanical issue with some bowstring that's leading to the increased DPC, or whether perhaps there's even some gapping going on, which could be a sentinel warning that the patient hasn't been able to make a full composite fist. And with increasing efforts, which oftentimes happens with therapy, you're on your way to a rupture. So those would be some of the things that I'd want to rule out. But in general, probably adhesions, and I would wait as long as possible. I do like a relative motion splint, to Don's point, with this patient population as well, and I found that to be helpful.
So those are all great points. And I too believe that 2 months is too soon. I think just the biology of your repair, if you are relying on some extrinsic peritendinous adhesion formation to actually help with your vascular supply to your tendon, you do run the risk of a rupture if you're aggressively tenolysing the digit too early. I think one of the nice guides here, if you look at this picture, it's one of the signs that we learn in medical school of rubor. And sort of as you flex the finger here, you just see this sign where you have to give it an extra little bit of push, to Don Lalonde's point, that the skin is still hard. Here you get that relative redness or rubor along the digit as you try to squeeze it down into flexion. And it just suggests that the wound is not mature. I think that the keys to the tenolysis have been discussed. I think when you stop making progress, I like to tell our patients that progress is our good measure as to when to decide to embark on a tenolysis. For me, again, it's probably somewhere closer to 4 to 6 months, erring closer to 5 to 6 months. And this is just being prepared, and tenolysis knives are certainly nice tools to have in your toolbox. They're Roy Meals design, but that you can cut the pulleys as you do this, so you have to be somewhat familiar with them. And at the same time, you want to restore this freely sort of sliding pulley beneath your pulleys that you want to preserve along the way where you can, to prevent tendon bowstringing. So I know we're a little short on time, and I just wanted to sort of sum up here. We've had some wonderful talks by our faculty, and thank you to Drs. Seiler, Lalonde, and Osei for their wisdom. These are challenging subjects, and as somebody who did some repairs in fellowship with lots of canine repairs, it was always amazing to me that no matter how well staged and standardized your repair, you still ended up with ruptures. And I think our goals of trying to advance our technical abilities, whether it's by the numbers of sutures we put in, to the way that we vent our pulleys, to making sure that we've got a good sliding pulley at the time of our repair without gapping, is really critical. And I think Don's introduction to many of us for Wallant has been very helpful. So for this particular unique zone, recognize the pertinent anatomy, really respect the biology of the repair. And every time you grasp your gliding surface of the tendon, if you remember Dr. Osei's pictures from the vascular studies, think of each time you're grasping the tendon as disrupting those small peritoneum-related vessels. And then consider associated injuries in terms of your post-repair rehabilitation protocol. That's really critical to individualized treatment, and communicate this with your therapist. And that's really, really the key. You don't want to send somebody out with a 2-strand repair that follows a cookbook repair for early active motion, because they're going to end up with a rupture. And don't burn bridges. Don't start your tendon reconstruction with an immature wound or something that you're going to have to come back to and ultimately may cause you to fail your reconstruction. So thanks to the staff and the faculty. Thanks to Warren and to Jerry for a fantastic series. And thanks for your attention tonight, and hope everyone has a good night.
Right. Thank you so much, Fraser. Really want to thank the faculty again. Thank you, Fraser, for organizing and also moderating really a fantastic education hour for everybody. Certainly learned a lot myself, but a lot of great pearls and gems for the fellows throughout the year. Sometimes you're going to be operating alone in the middle of the night with these very challenging injuries, or work with the attending or other faculty throughout the year. So I think a lot of pros to take home. These are still very challenging. I think some of the tips from today hopefully will make our outcomes a lot better. Certainly have had failures myself. And also just throughout the year, hopefully the faculty and fellows really encourage everybody to try and join on the webinar. Hopefully this will be a great series for the fellows throughout the year, even as we try and return to normal. Hopefully a little bit more normal next few months for everybody. But stay safe. But the next webinar is going to be 4 weeks, and we're going to go back to a standard format. Please reach out to me. We haven't established the faculty or fellows for the next webinar quite yet. So if you are interested, please reach out to myself and Warren as well. But really appreciate everybody's time, and this has been fantastic. Thank you.
Yeah,
Thanks,
nice
everyone.
job, guys.
Thank you, everybody.
This was excellent. Thank you guys for your